The record. Oh, there it is. Got it.
Welcome to
back.
Talk with the Doc. Here's
Go
Dr.
ahead.
Leichliter.
Present. Welcome back, everybody. Sorry I missed last month. I was in Disney World and my wife wouldn't let me broadcast from Disney World. But hopefully you got the extra session by coming to the Living Well conference, which I thought was fantastic. And so hopefully everybody was there and hopefully everybody enjoyed it. But welcome back to our typical Talk with the Doc session. I am Dr. Leichliter. For those of you who don't know me, I feel like most of you do, but if you don't, I'm Dr. Leichliter. I'm a movement disorder specialist here at Allegheny Health Network, sitting in my office here at Allegheny General. I'm going to answer some questions that you have, and Casey's right. The best way to get a question to me is to send it in the text chat box. I could hear, so for those of you who are typing, you can't hear, it might be your speakers. At the end of the day, everything you hear is going to be my opinion. I am merely one person with one person's opinion, but if you go to other neurologists or other movement disorder specialists, they may have various opinions or differing opinions. I like to think everything that I say comes from as best knowledge as I can find. But again, if I do end up kind of giving you my actual opinion or something that I'm not sure is accurate, I'll throw up some quotation marks, and that way you know I'm making stuff up. The other thing I like to warn people of is this isn't a great place to kind of get one-on-one or personalized care. This is a great general forum. So telling me you have this, this, and this, and you're on this and this, what do you think we should do next? Probably not a great idea. My answer is going to be, you should probably talk to your doctor. Casey, some people can't hear. I don't know if there's anything that you're noticing. You can hear me though, right? All right, just checking. Then it's probably a speaker problem. All right, with that, I'll get started with some questions that were emailed. There was actually a lot of questions that were emailed. So I'll start with those, but you guys are more than welcome to type questions into the chat box and I will get to those after the fact. So a question that I got first was, why is it that one day a Parkinson's person or a patient with Parkinson's feels okay and the next day is terrible? And I get this question all the time. And I don't have a great answer because it does seem odd. But I hear it in patient after patient after patient. I'll have good times, I'll have bad times. I'll have a few days where I don't even think I have the disease. And then I have days that are just terrible and I can't move. I don't know the answer as to why there's so much fluctuations. I have an idea, and my opinion is that, you know, how you're feeling at any given time is related to the level of dopamine, the level of the other chemicals that are in your brain. And those things are so dependent on so many variables, it's impossible to pay attention to all of them and really be able to pinpoint, this is why I feel good or this is why I feel bad. If you think about all the things that can impact the levels of your chemicals or your brain chemistry, I mean, it's everything from, you know, how you're feeling that day, to the medications that you've taken, to how much sleep you've gotten, to what you ate that day, to how busy you were the day before, you know, how much stress you're under. There's so many different variables that I don't think it's very easy to pinpoint patterns or pinpoint things. I always ask my patients to try, you know, is there anything that you did, any pattern, any relationship to medications, anything that would have triggered it? But so many times I just hear, no, it just seems random. And so while that is something that I hear all the time, it's not something I have a great answer for or a great explanation for, but my guess is probably something along those lines. I have a friend that was just diagnosed with PSP. That would be progressive supranuclear palsy. When I researched it, I learned that this is sometimes mixed with Parkinson's disease, but I do not see the connection. Do you accept patients with this disease or another specialty in the hospital with some other things? Unfortunate diagnosis, and I agree. And so at the end of the day, just to kind of make this a more broader topic. So, and this actually I'm going to speak on because the last question that I got emailed is, what's the difference between Parkinson's disease and Parkinsonism? And this also plays a role or dovetails into it, but I'll answer that question in a little bit. So progressive supranuclear palsy is one of the so-called Parkinson's plus conditions. And generally we think of 4 different conditions that fall into the Parkinson's plus category: progressive supranuclear palsy, multiple systems atrophy, cortical basal syndrome, and Lewy body disease. And they are similar to Parkinson's disease, albeit different. And the idea is that they can start off looking like Parkinson's disease. So PSP or MSA can come in with some tremors, some stiffness, some balance problems. And oftentimes they are diagnosed as Parkinson's disease early on or early in the course. But within, fair or short order, they start developing other things, i.e. the plus part of the Parkinson's plus condition. And they each have different symptoms that I look for when I'm examining patients or when I'm listening to the story. And they all have different attributes or things that make me say, I think this could be PSP. I think this could be more than just a typical Parkinson's disease. And that can be a whole lecture in and of itself. But the long and short of it is, all of these Parkinson's plus conditions are related to Parkinson's because they have similar features, similar symptoms. But they end up having other things that make me think that this is not typical Parkinson's disease. This is something different. Probably the biggest downside to the Parkinson's plus conditions is that they just don't respond to medicines the same way typical Parkinson's disease does. Our choices of medicines are relatively the same. I have the same handful of medicines that I use for people who come with all of the same symptoms, but in typical Parkinson's disease, they tend to respond very well. And in the Parkinson's plus conditions, PSP included, they just don't respond as well. They don't have the same benefit. They don't get the same reaction. And that's kind of the biggest downside. We still try it, and there's still other things we can do. And I still harp on all these people about exercise. You'll never not hear me talk about exercise. But that's probably the biggest distinguishing factor and what makes it different. And one of the things that really tips me in the direction of thinking, well, maybe this is not typical Parkinson's disease. Maybe this is a Parkinson's plus condition. Is it common for folks with Parkinson's disease to have a problem with a runny nose every time they eat? Yeah, that's actually not an uncommon thing, not even just when they eat. I have a lot of patients that have a runny nose, and I liken it to the same, and I could be wrong about this, I liken it to the same kind of pathophysiology that the drooling comes from. So a lot of my patients with Parkinson's disease come in and they have extra saliva, extra secretions. Sometimes it runs out, sometimes it drools. And the same thing is true for a runny nose. And so the short answer is yes, it's actually pretty common. It's a common complaint that I get, and it's one of the harder ones to fix. I actually have better treatment strategies for the drooling than I do for the runny nose. One of the things I've had the best success with from a drooling standpoint is actually botulinum toxin injections into the glands, but you can't really do that in the nose or the nasal cavity. So it is a very common problem. It is a fairly big problem because it keeps people from wanting to go out and do things, but it's also one of the harder ones to fix. We do have some medicines that we use to dry up secretions, but almost invariably they come with side effects, and that's kind of what we have to work on. So that's kind of a short answer to that type of a question. What can we do for stomach pain? That is a great question. Other than the movement issues with Parkinson's, it's probably one issue that keeps you from being active. And yeah, the abdominal pain, stomach pain, the GI problems, all of this kind of gets lumped together, and it's a huge problem. And it's a problem for a lot of reasons. It's probably coming from the gastrointestinal tract. We know that slows down in Parkinson's disease. This is why a lot of people have constipation, slow stomach emptying, slowed swallowing, things like that. Top to bottom, the entire GI system slows down. And when you get distended, that actually triggers some pain receptors in the abdominal cavity. And that's where that dull aching pain usually comes from. But it's hard to fix. Getting the GI system to move better, speed up or pick up the pace is very hard. We have some medicines that we use for constipation, but not much for stomach emptying, not much for slow motility. There's some things that are used, but a lot of the ones that are used by the gastroenterologists actually can't be used in people with Parkinson's disease. They're medicines that can make your symptoms worse. And so the GI system and symptoms, including the abdominal pain, is really a challenge to work on. This is why I do refer a lot of my patients to gastroenterologists, although I honestly can't say that I found a gastroenterologist who is more versed in this, has more knowledge in this, has worked with Parkinson's patients or neurodegenerative patients more than anybody, or really has a good solution for it. I send people to the gastroenterologist really to make sure there's not something else going on, to get scoped and do all the things that we should be doing. But that's a really hard problem that I don't think we have a great solution for. always a work in progress. I think there are some studies going on different things, but I don't know that I've ever come across a great medicine or a great treatment to help with that. So again, coming back to the Parkinson's and Parkinsonism question, I will come back to that in just 1 minute. Am I familiar with the B1 therapy? And if so, am I currently using it with my patients? And do I work with patients on supplement, diet, exercise, and alternative treatments? Yes, not really, sort of, yes, and yes. How about that? So the short answer is yes, B1 is being looked at in Parkinson's disease. There is some thought that maybe Parkinson's disease is related to or caused by low B1 to begin with. And there are some studies, I think, coming out of Italy that suggest high levels of B1 tend to help people with Parkinson's disease. But again, much like the other supplements that I learn about or that I read about or that I hear about, I take it with a grain of salt. Unfortunately, it's going to be hard to really get a good recommendation from me, because you're not going to get good studies on these things, although I do think there are some going on. But to get the typical gold standard kind of double-blind placebo-controlled trial that we get for medications is just, it's fantasy to think that people are going to do that with supplements, with vitamins, so on and so forth. They're expensive to run, and you're not going to recoup your costs. Do I talk to people about supplements? Sure. And it's really more them asking me and then me giving my opinion, much like I'm doing right now. And my opinion on supplements is always fairly straightforward and fairly the same. There is some good science behind supplements. CoQ10 has a small study that suggested it was helpful. Glutathione has been looked at several times. The vitamins have all been looked at several times. These things have all been looked at, and they all have some basic scientific understanding behind them to suggest that maybe they would be a good idea in Parkinson's disease. A lot of it coming back to kind of free radical scavenging. So every cellular process that happens in your body has some sort of byproduct, and that byproduct has to be removed in waste in some way, or antioxidants, meaning you get these damaging things or parts of your cells that have to be cleaned out. A lot of them work on mitochondria. So there's a lot written about mitochondria function in Parkinson's disease or dysfunction in causing Parkinson's disease. And mitochondria are the powerhouse of the cells. And so you can imagine, if you don't have the energy producing parts of the cells working all that well, you can definitely lead to cell death. And so there is a lot of science behind these things. The problem is the trials and the studies are usually in animal models, cell line models, primate models, proof of concept things. And so you're getting an actual study in people in these things is really hard to do. And I try to reserve my recommendations for things that really do have good studies, good in-human trials, so that I can say, yes, this has been relatively proven, this is a good idea. But my other philosophy on supplements is I'm not against supplements. Again, just because there's not good data doesn't mean they don't work or they're not useful. It just means I can't recommend it and say, yes, you should do this. My general rules of thumb are as usual, which is as long as there's some science behind it, which a lot of them have, as long as they're not toxic, which I don't think I've ever run across one that's been harmful or toxic to people. And as long as they're not putting you in the poorhouse, because a lot of them can get expensive, then go for it. I do think that with more trials, more studies, more kind of work on these things, maybe we will be able to recommend some or more so than another. But again, until I really get good data, I have a hard time actually recommending something. I do talk to patients about diet a little bit. There's not as much written about diet in Parkinson's disease as there is written about exercise. Generally, what I've read is that kind of the Mediterranean diet seems to be the best diet for people with Parkinson's disease. I don't think that's really that much of a stretch. It's probably the best diet for everybody on the planet. Hard to stick to in Pittsburgh, no doubt about it. We don't have a lot of fresh fish. We're not by an ocean. We have a lot of processed foods, a lot of, easier things that people, tend to go to or be drawn to, which probably aren't all that good for you. And so I do suggest things like that, although I also recognize that has its limitations. Exercise, everybody here knows that I talk about exercise. It's my favorite thing to talk about. It's the closest thing we have that's proven to, be disease modifying in Parkinson's disease. And we're in the process of trying to prove that even more. And so every single patient that comes to me gets some sort of talk about exercise. I usually ask, what are you doing? How much? And then I ask why you're not doing more. That's kind of how it usually goes. So exercise, I definitely talk about. And other alternative treatments, again, I usually wait until patients bring it up. I've had plenty of patients talk to me about acupuncture, which some of my patients have had success with. A lot of my patients of a variety of type go to chiropractors, massage, things like that. And again, same idea. I do think they help. I don't have a lot of good recommendations for them, a lot of studies or definitive evidence for them. But I have had patients come back and say, you know what, they make me feel better. I move better. They're usually short-lived. They're kind of temporary treatments or temporary solutions. But hey, if it helps and it's, again, cost effective, because a lot of those things are not covered by insurance, then I think it's worthwhile. But I don't have a problem with any of them. I like this question when I read it. What happens to the extra dopamine, like from carbidopa, levodopa, that is used for your body to help with Parkinson's disease? Or is all of it used? I don't think I've ever gotten that question. I thought that was an interesting one. Well, a couple things happen to extra dopamine that's just kind of laying around. If you're lucky enough to have extra dopamine laying around, and a lot of people are not, they need every last drop of dopamine, and it really is used. But if you are lucky enough to be producing some of your own and the medicines are overshooting, then a lot of it does get reabsorbed. Your body is pretty efficient. Your brain is pretty efficient. It's not going to, have to reproduce or recreate dopamine every time you need it. It does get recycled back into the cell so that it can be used at a later time. Some of it gets broken down, and if it hangs around in between nerves area long enough, it will get broken down. But the long and short of it is a lot of it does get recycled and reused. Again, the hard part is again, with Parkinson's disease, you're not producing enough to keep up. And so at the end of the day, you're not storing enough, you're not really reserving enough to be effective or efficient. And this is why we have to supplement with the medicine, so on and so forth. But that's usually what we think happens at kind of the cellular level to the dopamine as it enters or is found in your brain. All right, then there was a last question, which turned out not to be a last question. So the sort of last question was, can I talk about the difference between Parkinsonism and Parkinson's disease? And then the second part of it was, do I agree with Dr. Kohler's description of the subject? Well, I tried looking up Dr. Kohler, but Allegheny Health Network would not let me look at Dr. Kohler. So I don't know the answer to the second part, but let me answer the question, the first part of the question. And this is a little bit subjective. So I have my own personal opinion on what I label as Parkinson's disease and what I label as Parkinsonism. But this is probably not standardized. And if you go to a different neurologist or a different movement disorder specialist, you may get something different. And I only know this because I've gotten patients from other people diagnosed as Parkinson's disease, and then I see them and I change it to Parkinsonism. The best way I describe this is Parkinsonism is the umbrella term that covers everybody who has the symptoms of Parkinson's: the tremor, the stiffness, the slowness of movement, the balance problems. So again, remember, the diagnosis is really based on the motor symptoms. There are plenty of non-motor symptoms, and we recognize that the non-motor symptoms are usually more important than the motor symptoms and quality of life. But the diagnostic idea has been around forever, and it was made up back when we really focused on the motor symptoms. And so the diagnosis is based on the motor symptoms. So anybody who comes to me with tremors, particularly a resting tremor, stiffness or rigidity, particularly cogwheel rigidity, bradykinesia or slowness of movement, and postural instability, gets labeled as Parkinsonism. That is really the definition of Parkinsonism. And this is where it becomes my opinion. In my opinion, if you are typical age, typical presentation, typical progression, typical response to medicine, if everything is relatively typical, nobody's actually typical, but as long as you're you're in the ballpark of typical, I usually call you Parkinson's disease. If something is atypical, especially when I'm first diagnosing somebody, or before I see how they're going to progress, or before I see how they're going to respond to medicine, I'll usually leave the label as Parkinsonism. So if you're a young onset, I'll usually label you as Parkinsonism first, and then we see how things go. If you're older onset, same idea. If you have atypical symptoms, or if you're not responding to medicines the way that I think you should, or you're progressing faster than I think you should, then I'll probably call you Parkinsonism. Whereas somebody else down the street might say, no, this is Parkinson's disease. The problem is without a definitive test or a marker of these things, because again, I generally think that Parkinson's disease is more than one thing. Because there's no test or marker of these things, everybody gets lumped under the diagnosis of Parkinson's disease. I, again, reserve the diagnosis of Parkinson's disease for people who are fairly typical. But again, my idea of typical might be different than somebody else's idea of typical, so on and so forth. And so that is how I describe the difference between Parkinson's disease, which is the most common cause of Parkinsonism, and Parkinsonism. Parkinson's disease is also not caused by anything. We don't know why people get Parkinson's disease, at least not yet. So if there is a cause, medication-induced, vascular, some other chemical deposition in your brain or something else that's triggering the Parkinson's symptoms, then again, it's not Parkinson's disease, it's Parkinsonism. And likewise, if you have anything that's atypical or suggests a Parkinson's plus condition, then I also group those people in the Parkinsonism category. It's not typical Parkinson's disease. So hopefully that clarified the answer. Again, it is a little bit subjective, and realistically, it doesn't alter our plan or our treatment strategy, because the medicines that I have, the treatments that I have, the therapies that I have, I use for all the above, all of Parkinsonism. But people do kind of ask that question a lot, and they do want to know, well, some people, he told me I had Parkinson's disease, but you labeled me as Parkinsonism. What's the difference? And so that's not an uncommon situation. And it really comes down to kind of the typical nature of how things are going. Hopefully that made sense. Made sense in my head. What kind and amount of exercise is best for those with Parkinson's disease, and should it be strenuous or mild? This is the last question that I have in my email. This is also subjective, and I'm going to give you my opinion because, well, I'm the only one not muted, so you get my opinion. Let me backtrack. I don't think there's been any comparisons of exercise in Parkinson's disease. They generally have not been compared head to head. Aerobic versus strength training versus balance training versus Tai Chi and yoga. I don't know. There may be studies out there, but I don't know of any good studies that really compare them head to head. And generally, my rule of thumb, and our rule of thumb as a community, is that exercise is good for you. Doesn't matter what kind of exercise you do, all exercise is good. So usually what I recommend is find something you like to do, because I'm going to ask you to do it a lot, and you got to do it forever. And if you hate it, you're not going to do it. If you like it, you're more likely to do it. So the best thing is to find something you enjoy doing, find something you like to do, and do it a lot. My personal opinion is that a combination of different kinds of exercise is better than one or the other. And what I mean by that is, I think if you can find something that combines cardiovascular exercise, really getting your blood pumping, getting your heart rate up, resistance training, i.e. weightlifting, resistance bands, things that strengthen muscles, and balance training, whether it be Tai Chi, yoga, just balance classes, things like that. If you can find things that cover all of those bases, I think that's the best choice. And really, I think, my personal opinion is that the combination of all of those things is better than any of those individual. I really think there's benefits to getting your heart rate up, getting your blood pumping. We know that helps mitochondria function better. It cleans out cellular debris. It's good for a cardiovascular standpoint. Tons of benefits. In fact, the recommendation is 150 minutes a week of exercise that does get your heart rate up to 75 or 80% of your max heart rate, which I think is 220 minus your age. And so the recommendations are for exercise that are cardiovascular in nature. But I think there's a lot to be said about weightlifting and strength training, strengthening up your core, strengthening up your back, strengthening up your legs. I really do think that people with strong muscles tend to be better on their feet. They tend to fall less. They tend to have better balance, and they tend to do kind of better overall. But I also think balance training is really important, actually working on walking in balance and things that might, trip you up or work on your balance centers, because again, falling is your most dangerous problem. That's the number one reason my patients end up in the hospital. And so I do think specifically working on balance is a good idea. All of them have pluses and minuses, no doubt about it. And I really do think that the combination of all of them are the best. Now, again, that's my opinion. That's not written anywhere. That's not proven. I just think it makes logical sense. And so that's what I would recommend. But at the same time, if you're somebody who says, you know what, I hate going for a walk, or I hate the gym, well, then I don't think it makes sense for me to say, hey, you should really go to the gym, because that ain't going to happen. If you come in and you tell me I hate a stationary bike, and I say, well, the best exercise in the world is a stationary bike, chances of that being successful, pretty low. But if you're able to find something you enjoy doing, if you're able to find something that you don't hate, that you can motivate yourself to do, that you find fun or interesting or exciting, well, then I do think you're going to have a much higher success of, sticking with it, doing it as much as somebody like me is going to tell you should do it. And I think we're going to have a better success with what we're trying to accomplish. So that's kind of my general thoughts on exercise. Again, all exercise is good exercise. I really do want to stress that. And so again, as much as you can do, the strenuous question is interesting, because generally we think of more strenuous as better, but at the same time, we know things that are less strenuous, like Tai Chi, yoga, Qigong, have all been shown to be effective in people with Parkinson's disease. And so while I do think there is a lot to be said about strenuous exercise, higher intensity exercise, really breaking a sweat, really getting your heart rate up, there's also something to be said about at least layering in some of those less intense exercise. And again, I think it's the combination that really is going to help you do the best. All right, let me jump over to here. All right, so after we got past everybody who couldn't hear me. All right, does the new time-release carbidopa-levodopa help with downtimes? Well, there's a bunch of different time-release carbidopa-levodopas, and the idea is that they help with downtimes. And we try to use them as such. Are they great? Well, no. I mean, not great based on my opinion. Are they good? Yeah, in some people. Are they better than regular Cinemet? In some people. Some people like them, some people don't like them. And much like everything else, it all comes down to trial and error. You really have to figure out what you're trying to accomplish. Sometimes I'm able to kind of smooth out ups and downs by switching to a longer release carbidopa-levodopa formulation. Sometimes it doesn't work and we end up switching right back. This is a great conversation to have with your doctor. And again, really the goal is, what are you specifically trying to accomplish? And as you'll find, there's always like 6 ways you can try to accomplish the same goal. And so one way is not always right for everybody. And it really does come down to trial and error to figure out what's the best choice for you. What are we trying to accomplish and how do we try to do it? And you just have to talk to him. I will check out Dr. Craig Kohler's website at some point, and I'll get back to you on that one. Are any kind of seizures known to occur with PSP? Seizures can occur with everything. Not that I think there's a high correlation with my Parkinson's patients, at least not that I can think of offhand, or even my Parkinson's plus condition patients like PSP or MSA. But the caveat to that is anything that disrupts the outer part of your brain, the cortex of your brain, i.e. the part of your brain that we think does the thinking, can lead to a seizure. So a seizure is really just an abnormal firing of your brain cells that becomes out of control. And so we know that any kind of damage, so that usually we think about things like a stroke or a tumor or a traumatic injury, can trigger a seizure. But as you age, and particularly as you age with some of these conditions, more of the Parkinson's plus conditions, but not outside of the realm of possibility with Parkinson's disease either, your brain shrinks. You get some atrophy or shrinkage with typical aging, but you definitely get a little bit more with any of these other conditions. And you can imagine that shrinkage of your brain is in a way damaging to it. And so if you do get enough damage in any one area, it can trigger a seizure. So I can theorize, or I can logically make an argument that there probably is a higher risk of seizure in conditions like this. In my own experience, I don't know that I've seen that a tremendous amount or really seen a correlation with that. But I also wouldn't be surprised if somebody came up with a paper or showed me a report that said, yes, people with neurodegenerative conditions have a higher incidence of epilepsy or seizures. I'd say, I guess that makes sense. Okay. Again, I don't know if that paper exists, but if it does, I wouldn't be surprised. Do I encourage my patients to exhaust all possible non-invasive therapies, yoga, Reiki, meditation, before the impact of brain surgery? No, I would have to say no. Do I talk about yoga and Reiki and meditation and acupuncture and chiropractor and yeah, all the time. But do I think somebody has to try them all or exhaust them all before I would send them to the operating room? No. I know a lot of patients view deep brain stimulator surgery or brain surgery as kind of a last resort, but I don't. Brain surgery is another tool that I have to try to get patients doing better or keeping them doing as well as possible as long as possible. Is it my first choice? No. That I can say pretty certain. I'm never going to send somebody to the operating room without trying something else first. And general rule of thumb is you kind of have to have disease for a few years. We'd like you to try a couple of medicines and maybe the medicines work, but you have problems with them. I mean, there's definitely some rules of thumb for patients that we send for surgery. But it's not a last resort. It's not like I say, well, let's try every single thing that I know of under the sun. And then if that's not working or you're not doing well, then I'm going to send you to the surgeons. Really what I'm looking for is what's the best choice? If I think brain surgery is going to be the best choice or give us the best chance of a higher quality of life for any length of time, and I think that's a better chance of giving you that than say trying another medicine or sending you for yoga or Reiki, I'm going to send you to the surgeons. My goal is not to try everything or use every medicine or every strategy that I can think of. And this includes, my goal is to get you doing as well as I can. My main goal is how can I keep you functioning as long as possible, as well as possible, preferably on as little medicine as possible or as little intervention as possible. That's really always my goal. So every patient that comes to me, if you're my patient out there, that's my goal when you come to my office. It's not always easy and it's not always achievable or attainable, but that's always the goal that I have. And if I think that brain surgery, deep brain stimulator surgery, or even one of the other types of things, the high frequency ultrasound ablation or the duopa pump, if I think that this is the next best choice or gives us the best chance of a higher quality of life, then that's what I'm going to tell you. And that's what I'm going to suggest. And that's what I'm going to refer you to. And you may come back and say, but we didn't try this medicine over here. And I'll say, I know. That doesn't mean I don't know about that medicine over there. It's just that I'm ignoring that medicine over there because I don't have high confidence that that's what's going to give us the best quality of life. I have much more confidence in surgery in that case. That's why I'm recommending it. So again, hopefully that answered the question. I mean, at the end of the day, I'm not shy to send people to the operating table, but I'm also not eager to send people to the operating table. And so I kind of balance those two things. That is a great question and probably a common one. I'm taking over 20 medications for Parkinson's plus other medical conditions. Who would be the best person to go over drugs taken as to spacing, taken with or without food, what drugs taken together, drug interactions, etc.? I bet you everybody on this call has the same question because I very rarely see people that are not on tons of medicines. It's basically like every doctor you go to, you get another medicine, at least one. And so it's not uncommon for me to see people that are on 5, 10, 20 different medications, all with a variety of purposes. But I mean, there's got to be some sort of side effect, combination, interaction combination. You're right. In the ideal world, in my opinion, they may not like to hear this, but in my opinion, this is a great job for the primary care doctor. Okay. The problem with that philosophy is the primary care doctor gets about 4 minutes to take care of all those 20 different medical problems that you have that you're on a medicine for. And so to think that a primary care doctor is going to have time to sit down with you and go over all 20 medications with you and their side effect profiles and which would be good to take on an empty stomach and which wouldn't, and which ones you can get away with taking by themselves versus which one you need to take together or vice versa, it's just not going to happen. And likewise, I'm not going to have time to. There's just no way that we have time in even a 20-minute appointment visit that we can talk about all that. The hard part is there really isn't a very good solution for this or a good person to do it with. There are some. So I'm learning about a couple at Allegheny Health Network that have pharmacists, that have nutritionists or dietary people who can kind of go over, or different programs that can sit down with you and go over all your medicines and see what we need and what we don't, but they're hard to find. The patients that I've had go to them, I usually do get a report and they say, hey, we went over all their medicines and this is what we found. So there are places you can go. I don't remember the name of our program at Allegheny Health Network, although I know we have one. I'm sure UPMC has one too. But when you're on that many medicines, it probably is worthwhile to at least find a program like that, an outpatient pharmacy or there's probably other names of these people that I'm blanking on, but there are people designed for it. It's just they're underutilized and there's not that many of them, I don't think. But it is a really real problem. If you're on 20 medications, the chances of none of them interacting seem pretty low. The chances of no two of them having additive side effects seems pretty low. But at the end of the day, does that mean you can get away with not taking any of them? I don't know. This is where you need somebody to look at what you're doing and really try to give you a holistic picture of that. But that's hard to find and hard to do. I think you're going to see more of these. I know, again, the programs at Allegheny Health Network seem to be popping up. We have one both through palliative care to try to help people at home, to give people management. But now we have a supportive care program that I think is outpatient that I've been referring some patients to that's been doing a good job. And so I do think you're seeing more and more of these programs or these types of things coming up because I think everybody is starting to recognize that everything you just asked in that question is a really big problem. And that's something that we have to work on. So again, if you're my patient, send me a message. I'll try to get you to the people that we have here at Allegheny Health Network. But at the end of the day, maybe call your insurance company, see if they have something like that or somebody that can go over it with you and sit down with them and see what they think. I use proper technique to rise from a chair, but right after I get real clumsy and I shake. Not a typical tremor. I feel very often have fallen for 1 or 2 minutes later, freezing. I already try to take more Cinemet in addition to Rotari. Any ideas? Thank you. Well, it's a good question. And the question, I'll answer the question with a question because I don't think I have enough information here to really tell you what to do. But just as a broad topic, a lot of my patients feel bad when they get up, even if they do it right. And so the question is going to be, is it just that you're sitting too long and you're stiff? Is it an off phenomenon from a medication? Is it orthostatic hypotension? Trying to delve into why you're having these reactions when you stand up is going to be the case. Of that, I would say orthostatic hypotension is probably the most common. So this is where when you stand up, your blood pressure goes down. So most, and I'm going to put normal in quotation marks here, normal people, whoever they are, when they stand up, they have receptors in their carotid artery or carotid bulb that trigger your blood pressure and your heart rate to do certain things, to maintain blood flow to your brain. Those mechanisms, those receptors, those responses don't always work in people with Parkinson's disease or Parkinsonism. And so you stand up, those mechanisms don't kick in or take effect. Your blood pressure goes down. Your blood all pools in your legs. You don't feed your brain with enough oxygen and blood. You feel lightheaded and you feel terrible. At its worst, you pass out. Now, again, I don't know that's necessarily what's causing the clumsiness or tremors or things like that. It could just be that you're stiffening up because you're sitting. Again, if anybody sits long enough, they'll stiffen up. It could be that your medicines are wearing off or things like that. And trying to delve into the timing, the pattern, so on and so forth is probably the best way to try to work on that. If you need, again, just because you're on more Cinemet Rytary doesn't mean you don't need more. Maybe you need something else added in. Maybe we need to work on your blood pressure. Maybe you need to drink more and eat more salt to try to boost your blood pressure. Maybe you need compression stockings. Maybe you need every single thing that I just said. Tough to say. But at the end of the day, any patterns that you can recognize, anything that you can kind of try to attribute it to is going to help your doctor figure out what to do about it. Yes. I know that exercise is disease modifying, but at the same time, does it use up more of your dopamine? Yes. And so this is why a lot of patients will come and tell me, but I actually feel worse after I exercise. I shake more after I exercise. I'm tired and I'm fatigued after I exercise. And the short answer is yes, you're burning up more of your dopamine to move at a higher intensity and more. But the long run or the long-term benefit, very, very much so over kind of outweighs the short-term more difficulty that you're having. And with more time and repeated exercise, you tend to tolerate it better. And so the short answer is yes, you do use up more dopamine when you're exercising or when you're more active, but it's still the best thing for you from a disease modification standpoint, and I still highly recommend it. Have I tried Norians in patients with Parkinsonism? Yeah, I have. And it's been okay. I've had some people who like it. I've had some people who didn't think it did anything, much like every other medicine or add-on or adjunctive kind of medicine in addition to carbidopa, levodopa, the typical dopamine agonists. Again, I've tried all of the other medicines you can think of, and I've had some success with all of them. And I've had some patients not have success with all of them. And again, this comes back to the trial and error pattern of what we have to do to really see what it takes to get people doing better. It also depends on kind of what are we trying to solve? What are we aiming for? What are we trying to accomplish? And that helps me decide which drug to use or which medication to try. But that's a long answer for yes, I've tried Norians in some patients and I've had some success. It just depends. I thought too much dopamine caused paranoia or psychosis. Is everyone different? Again, yes. We do think having too much dopamine leads to some of the side effects that you get in Parkinsonism, particularly dyskinesias, hallucinations, paranoia, so on and so forth. But it's not just too much dopamine. It turns out that there's actually a lot to do with the receptors themselves, how sensitive they are to the dopamine, how they've changed over time. Your body is not static. Your brain is not static. It's changing constantly. You're getting new connections constantly. You're losing connections constantly. Your receptors are changing and evolving and reacting constantly. And so with the medications, again, what we think of as a lot of those side effects that you mentioned are a side effect of the way that we deliver dopamine to your brain. So believe it or not, it turns out that just giving pulses of dopamine is not really a natural way to get dopamine into your brain. Your brain doesn't naturally just put out spurts of dopamine 3 or 4 times a day. It's not how it works. But that's what we do with pills, right? You take a pill, it gives you a burst of dopamine, and then it wears off. You take another pill, same thing. And we think that it's actually that pulsatile nature, that hitting you hard and then wearing off, that leads to the receptor changes, that leads to a lot of the side effects of the drugs. And so it's not just, oh, you have too much dopamine, that's what's leading to your problems. It also comes down to the receptors, how long you've been doing it, how we've been doing it, so on and so forth. And so, again, everyone is different. Everyone has different responses to medicine. Everyone has different mechanism of breaking down dopamine, restoring and recycling dopamine, so on and so forth. But it's a lot more to it than just, oh, you have too much dopamine. It's a great question. What can one expect at an initial Parkinson's disease evaluation appointment? Do you need medical records from all types of doctors and therapists I've seen in the past couple of years? Thank you. Everybody's different. So again, depends on who you're seeing. I can't speak for other neurologists, other movement disorder specialists. I can only tell you what I think. So the vast majority of an initial appointment with me is what you tell me and what I see. Are records important? Maybe. Depends on what they are. I don't need every record or every doctor that you've ever seen, every therapist that you've ever seen. But if you have an MRI scan, sure, I'll take a look at that. If you have a DAT scan, great. If you have another neurologist record or your primary care doctor's most recent evaluation, sure, that can give me some insight. But realistically, you're going to tell me every answer that I want to know. And your report is going to be infinitely more helpful and more useful and more accurate than anything that's written down about you, right? Because everything written down is written by somebody else, and it's their interpretation of what you told them. Your actual report is what's going to tell me the most concrete, the most definitive, and the most accurate information. So in my office, when somebody comes to see me, I'll look at pictures, I'll look at reports, but The majority of the decisions that I make and the opinions that I come up with are based on what you tell me and what I see when I examine you. And those two things, again, you don't have to study for that. You don't have to bring anything for that. You just got to show up, tell me what's going on, tell me what's happened, tell me how things have gone, and let me take a look at you. And that's going to help us decide what we think is going on. And then the rest of the, initial evaluation is me telling you about what it is, how I came to that conclusion, what to expect, what we're going to do. And that really encompasses the entire initial visit of somebody coming to me for a Parkinson's disease evaluation. I've been waiting for this question. I actually didn't get this question nearly as much as I was expecting to get it over the past week or two, which is, what does the discovery of the Parkinson's biomarker mean for those who have PD? Anything in the short term? The Michael J. Fox Foundation put out this really earth-shattering, big breakthrough, which was that they found a biomarker for Parkinson's disease, which is really just a version of alpha-synuclein, which we've known about for a long time. And it seemingly can tell the difference between people with Parkinson's disease and those without. What I'm not sure of is, does it really distinguish between the different Parkinsonisms, the Parkinson's plus conditions, the atypical version, so on and so forth. So I have a little bit more reading to do on it. But the long and short of it is two thoughts on it. One is it's Spinal Tap, and I get to just see all of you raising your hand for who wants me to jam a giant needle into their back to see if this is true or not. And two, the biggest downside that I have and why I haven't been as overly excited about it is, what are we going to do with it? Again, the second part of the question, does it have anything in the short term? And the unfortunate or short answer is no. It's not going to change anything I do. My treatment strategy is not going to be any different. My recommendations for therapy and exercise is not going to be any different, because I'm not basing those treatment strategies on a definitive diagnosis. None of the medicines that I have, none of the therapies that I have, none of the recommendations that I have for exercise are based on or are disease specific. In other words, you don't have to have a diagnosis of Parkinson's disease for me to put you on carbidopa-levodopa. Guess what? People that have PSP or MSA or Lewy body disease to some extent, or atypical or medication drug-induced Parkinsonism or vascular Parkinsonism also usually get a trial of carbidopa-levodopa. They also get a lot of physical therapy, speech therapy, and occupational therapy. They also hear me rant and rave about exercise. So I don't think it changes anything, at least not yet. That's not to mean that I'm not excited about this breakthrough. I am. But I'm excited about it in terms of long-term projection. And the reason is we need a biomarker. We need a test, because until we have a test or a marker of disease progression, it's really hard to know if medications are disease modifying, or if we're targeting the right thing, the right patients, the right people with the medications that we're trying to come up with. And so while I am very excited that they have found a biomarker, something that I think can really tell the difference in Parkinson's disease, I really view it as step one of about a 15 or 20 step process to get us to where we want to be, which is disease modification and a cure. Again, I think we're still a ways away from that. And I think this was a very important step one, but I don't think it actually helps us in the short term. I don't think it helps me take care of patients any better than I already do right now. And I'm not sure it gives us any more information that we can use to our advantage than we already knew. But I'm actually surprised I haven't gotten that question nearly as much as I was expecting to get that question after I read and after that came out. And I just skipped over a bunch of stuff. I didn't see any actual questions in there. Talked about Parkinson's versus Parkinsonism. Do I feel that Parkinsonism doesn't progress or seems less severe? That's a difficult question. Okay, so let me backtrack a little bit on that. In general, in my experience, Parkinson's disease responds the best to medicine. So typical presentation, typical symptoms, typical response to medications. Is that always true? No, probably not. But I think it's, in my experience, that's been the most true. So usually when I'm talking about a Parkinsonism, it's usually an atypical version, something that's progressing quicker, not responding to medicines very well, or a Parkinson's plus condition or something else. And usually I think those types of things do progress a little bit quicker or faster than typical Parkinson's disease. Not always. And when I'm labeling something as Parkinsonism, I'm not necessarily using it to predict, oh, this person's not going to do well, or this person is going to do great. I'm really just using it as a description of what I'm seeing. If something doesn't add up or isn't a fit for what I'm used to seeing in Parkinson's disease, then I'm not going to label it as Parkinson's disease, because I like to keep the diagnosis or the label of Parkinson's disease as clean of a label as I can in my patients or in my world. And so if I see something that is atypical or doesn't fit, then I'll usually label it as Parkinsonism. Now, again, that doesn't necessarily mean that it's better, worse, or the same. It's just not typical. Usually when we talk about the Parkinson's plus conditions or some of the atypical versions, they do tend to progress quicker than typical Parkinson's disease, but I guess it's not written in stone. And so I don't think I would use it to classify somebody as better or worse. I just use it to describe what I'm seeing. So hopefully that helps clarify what I mean when I use the terms. I think that's the best way to think about it, not in terms of kind of what to expect or, necessarily progression speed or things like that, more along the lines of, are you doing things that I'm used to seeing in my typical patients with Parkinson's disease, or are you not? Very little experience with Divi. So Divi is the carbidopa-levodopa pill or that is breakable, and you can break it into half, you can break it into quarters. I did meet with the reps there at the meeting at the Living Well conference. And again, they told me, not that I didn't know about it, but they told me about it anyway. They were really kind of trying to suggest who would be the right patient for it. And I think what they were saying makes sense. I don't think I've ever prescribed it just yet, but it's on my list of things that I know that I have in the back of my mind, that if I do find the patient who I think would benefit from it, I'm all for it. What I tried to explain to them, or, again, not that I'm against Divi, I just haven't used it yet, is, when you think about the problems that it might help, which is, patients who are taking a quarter of a pill, or patients who just need a little bit less so they're not dyskinetic and they can move. When you think about things like dyskinesias or motor fluctuations, again, there's not just one way to solve a problem. There's usually like 6 or 7 ways we can solve a problem. And so again, I'm sure that I will come across a patient where I think, hey, this is a great idea. Let's try this and let's see what happens. But right now, again, when I see patients, there's a lot of other ways we can try to target the problems. And that's probably why I haven't used it just yet. It hasn't been the one that I think gives us the best chance to solve the problem. I'm sure I'll run into that, and I probably will prescribe it and use it at some point. It's just that's my experience thus far. I don't know. Is there any benefit from doing high-level executive functioning skills every day, i.e. bill paying, money and household management? You could lump brain games in there, Sudoku, crossword puzzles, learning a new language, which I vote. My personal opinion is yes. So my first thought is that, yes, this has to be good for your brain, right? If you don't use it, you lose it. So the more you think, the more novel ideas or tasks that you make your brain do, the better you're going to do. And I think that logically makes sense. And I really do think that it is probably true, but I just don't have any evidence to back it up. There's been mixed reports on brain games, on cognitive training, things like that. At least in terms of studies. And so at the end of the day, even though my general thought is that, yes, they are good and yes, they are helpful, I don't know that I can say that without any uncertainty.
Dr. Leichliter, can I just say something today? Because we just had a seminar right before this by a PMD Alliance that covered brain functioning. And they had a researcher on there that actually proves, and this is for anybody over 65, we have declining brain function. And she had evidence that there's a difference between brain, what did she call that, Vic? I'm losing my mind. Yeah. Brain, like sensitivity versus training. Mm-hmm. And like Sudoku and games like solitaire and crossword puzzles are just set, and there's no proven way that stops you from getting dementia. But there is a way of brain training that stops it. And she mentioned brain HQ, who mentioned a specific program that actually has proven results to slow the decline, reduce the risk of getting dementia, and you only have to do 20 hours, and it's an app, computerized brain training. So they did, and that's for anybody, but with people with Parkinson's, it would probably be good too, but it's for anybody.
Did they have a study that they cited by any chance, or do you know? Because I'd love to read it.
It's her work, and there's the clinical trial on that is called PACT. I got to go get my notes that I took on that, but that was just today at 3:00, and that'll be available on video on their resources page. And I forget the name of the woman that was presenting, but she had the actual study that showed that, and it's a specific game. Like you can train for speed, memory, or another thing. I need to train.
Apparently, you need some training.
Right. But she said that this one thing is the best, and it shows you the 3 kinds of brain training you could do, and it was for the speed training. So,
okay. Well, let me look. I'll see if I can find her talk on the PMD Alliance. I've been on there. I know what they have. Let me see what evidence they have. Again, I don't believe anything until I see the evidence. And again, just because somebody tells me that it's been studied and proven doesn't mean I believe them, especially if they want to sell you something. So I'll have to look into that too. But let me look. Let me see what she said. Let me see the research that she's citing or what she's quoting, and I'll get back to you.
And somebody asked if it was free. I went to it and looked at it. I think you can use it for free, but there is a subscription version too, but you can use it for free. I'll try to find my notes and put it in the chat.
I was going to say, if you find it specifically, send it to me. I'd love to look at it.
Yeah. The other thing that on Divi, I talked to Jimmy Chu afterwards to find out how he stays up to do that much exercise. And he microdoses his dopamine with that Divi. And I said, well, we're trying to do the same thing and we're cutting it into 4. And he goes, you're not getting a consistent dose. And he recommends Divi. But then when I talked to our neurologist to get that, he said he hasn't been successful in ever prescribing it because it's on no one's insurance formula.
Well, and so I have my own opinion, and I have my own opinions on that. Generally, medications that are brand are hard to get. Just facts of life. And every drug company and every drug rep that I talk to gives me the same story, which is, oh, but if you do this, this, and this, everybody gets it for nothing. Not exactly, but you get the idea. And then when I go to do it in real life, it's not like that at all. And so at the end of the day, yes, if you're microdosing or if you're breaking pills into quarters or even less, believe it, I've had people try to do that. The chances of you getting a consistent dose is probably not good. And Divi's probably a great idea. How to get it? Well, that's a whole different story. Again, that comes down to insurance. That comes down to pharmacy. That comes down to a lot of things that are outside even your doctor's control. So he's probably right. Doesn't mean we don't try. I try getting stuff I get told no all the time. Welcome to the world of medicine. But at the end of the day, yeah, I think in those cases, and I actually didn't ask Jimmy Choi what he does or what he is, but if he's on Divi, it makes sense if that's how he's using it. Again, I think at the end of the day, it's going to come down to personalized medicine. What makes the most sense for you? And then what kind of hoops do we have to jump through to try to get it? But yeah, welcome to the world of medicine. That's for sure. Yeah,
because they say it's regular carb levodopa, so they don't have to do brand, and so you can't really get it. It's like under $400 a month or something.
I am definitely, I'll believe it when I see it kind of guy. Well, thank you. Send me that and put it in here and I'll look it up and I'll let you guys know next time. All right, what do we got? A couple more questions? All right, a couple more questions. I think. Yeah. What about lack of sleep? What are good medication to help one sleep? Depends how you define good. I don't know that I have a good medicine to help people sleep. They all come with a price. So probably what I start with for people who are having sleep problems is melatonin, over-the-counter melatonin, which I know there's been pluses and minuses written about melatonin, but melatonin has some benefit in REM behavior sleep disorder in my experience, and so that's what I usually recommend first. But my experience with melatonin is that maybe it helps initially, and then as you get used to it, it doesn't work anymore. And so then I try a whole host of other medicines, and again, it depends on what the problem is. If you're not sleeping because you're wearing off, It's not uncommon, and I run into this all the time. People take pills every 3 hours during the day, and then they go 7 hours overnight, and they wake up right in the middle of the night, and they say, well, I wake up every night at the same time. Well, because your pills are wearing off. Just like when you're awake, when you're asleep, your pills are wearing off, and that's what's waking you up, in which case we need to do something different from a dopamine standpoint. If it really is more of a primary sleep problem, there are sleep specialists for stuff like this. But I'm not uncommon to use Klonopin. Again, Klonopin is probably the best for REM behavior sleep disorder or acting out dreams medicine. I've used Trazodone. I've used Remeron. I try to stay away from the Lunesta, the Sonata, those kind of sleep aids, because I don't like the way people react to them. In my experience, that's just my personal opinion. There are other people that might use them all the time and have good success with them, but that's kind of the progression of medicines that I'll come to in terms of sleep. But really trying to get to the bottom of, is there a underlying cause or pattern or trigger? That's what I would look for first. All right, I got time for one more. And by time for one more, I said I'm making up time for one more. Because Casey hasn't kicked me out yet. All right. Cause Parkinsonism. Medication caused Parkinsonism, but it's been questioned by the new neurologist. Sorry, I'm skipping to the end. So the main question is again, it sounds like there's been questions about whether or not it's Parkinson's disease or Parkinsonism, maybe medication induced. And it sounds like initially medications may have helped, but now more recently, they don't seem to be helping. So realistically, trying to figure out, is it Parkinson's disease or Parkinsonism? I know I made it sound kind of important, but realistically, from a treatment strategy standpoint, it is not that important. What we do from a medication standpoint or a treatment strategy standpoint is going to be the same regardless of what you have. I do have some patients that I put them on a medicine and initially it works great. And then they kind of start having more problems. And I'm like, oh, okay, more medicine is going to solve this. And then they try more medicine and they're like, yeah, nothing happened. And likewise, I've had patients where, initially medicine doesn't help and I ramp it up and they do get success. And so that's a hard question to try to answer without knowing more about what's going on or what I would do. If you did initially have some success with the medications in terms of facial masking, stiffness, walking, then that's a good thing.
Dr. Leichliter, that's my question.
Okay.
What is in doubt at this point or question is whether I have any form of Parkinsonism or Parkinsonism at all either.
Well, if there's a question that you have any Parkinsonism, that sounds like a good thing.
I wasn't having any off times when I missed a dose.
Well, and I've had that too, where I've had some patients that I look at them and I'm like, oh, this is Parkinson's disease. And then, I put them on a little bit of medicine, maybe it helps. And then a year later, we're still doing the same thing. And another year later, they come back and they're still doing great. And I'm like, hey, I'm the best doctor in the world. And then 4 years later, they're still the same. And 7 years later, they really haven't changed. And they're like, do I really have Parkinson's disease? And I'm like, I don't know. I'm not sure. A DAT scan might help, but again, do we really need to go through that?
I had a normal one.
There you go. So again, that would be against the diagnosis of Parkinson's disease. But I would argue that, and again, I know this is going to sound terrible. I know patients really do care what they have. I would want to know what I have too. But when you're coming to me and I'm telling you this is what we should do, what you have is not actually that important. If you have Parkinson's disease and you come to me with tremors and stiffness and slowness of movement and balance problems, I'm going to try you on a course of medicine. If your DAT scan's normal and you don't have Parkinson's disease, but you come to me with tremors and stiffness and slowness of movement, I'm still going to try you on the same medicines. What the underlying cause is doesn't actually help me dictate, decide, treat you any different. So in your case, again, do you actually have Parkinson's? I don't know. Do you not? Doesn't sound like it. But if you came and said you were still having stiffness and balance problems, I'd probably still try the same medicines. If you're better, if your symptoms are better, all the symptoms that you used to have, because maybe they really were drug induced and we're not, and you stopped taking the medicine and now it's not a problem and you're better, I don't care why you're better. You're better. That's the take-home message. And so at the end of the day, a lot of people really like a diagnosis. Insurance companies love diagnoses, right? You can't get anything without a diagnosis. And I get it, because I would also want to know specifically what I have. But when you come to somebody like me, or if you come to me and I'm trying to figure out what we're going to do with you, or what medicines we're going to try, or what are we going to take you off of, or what am I going to recommend, the actual underlying diagnosis doesn't really make a difference. And so again, I think in your case, that's great. If everything is better and you're improved and you're off of medicines and all signs are pointing in a good direction, fantastic, enjoy it. But if your symptoms come back, or if something changes or something gets worse, then you know what we're going to do. It's probably going to be the same course, in which case we're going to see what we can come up with.
Thank you.
All right, Casey, I'll pass it back to you. I think I'm over my time anyway. Again, Vicki, I will take a look at this and I will try to get back to you on what I think, because I have no problems giving you what I think. And Casey, I'll let you take it away after that.
Thank you, Dr. Leichliter. That was another wonderful talk with the doc. Thanks for going over a few minutes. We'll resume next month on the first Thursday at 4:45 p.m.